why are we, I keep talking about trying to find the person and the patient. Or another way of thinking about this is that what are the relational aspects of clinical therapeutics, okay? So we're going to work off that. And this is a slide that Don once shared with me, or some version of this from some research in psychotherapy, which shows that when you think about the percentage of variance in the outcome of psychotherapy studies, meta-analyses of psychotherapy, what you find is that the quality of the therapeutic relationship is worth 30% of the variance in outcome. 15% of the variance in outcome is about the placebo or hope effect, the hope that the patient has that something good will happen. So almost half the outcome is determined by the relationship and the hope. And then only 15% of the outcome has to do with the particular technique that you're using, whether it's psychodynamic or CBT or whatever kind of specificity you have. And then 40% of the outcome is stuff outside the therapy, the life events that the patient experiences. So what we're looking at is the power of the psychotherapeutic relationship to influence outcome is huge, okay? So that's one of the principles. When we think about the evolving healthcare system, we constantly evaluate it is it safe, timely, equitable, efficient, equitable, efficient, effective, and patient-centered. So this is kind of a principle guiding system. And then I sort of put as a kind of, polarity that you have to be good at in both ways. Can we be good at both evidence-based medicine, evidence-based care, measuring our outcomes, and also finding and respecting the person and the patient? So why is that important? One of the things we just showed you was that the outcome is largely dependent, particularly in chronic conditions, on the quality of the relationship. And then what I really wanted to say is, this is what I think we're trying to teach you in the residency program. And this is the way we're trying to work. There's 5 steps to what we're doing. The first thing is, how do you find a person? And I'm going to talk to you about that for a few minutes. What we're going to do today is this. I'm just giving you a simple rationale, and then we're going to look at an interview that we had with a number of the residents when they were using the maps that we give for suicide risk assessment and managing suicidal patients. How were they working relationally? And they're going to teach you about how that works, okay? So first you find the person, then you enlist that person as your ally in the treatment. The person becomes your co-investigator. So what you're doing is you're trying to find someone who's going to become a co-investigator with you and ride in your car down the treatment path, okay? Then you have to develop a shared map. What are the goals of the treatment? What's the problem? You work empirically from your evidence base, and then as a co-investigator, you discover what works for this particular patient at this particular moment in time. Because the problem with evidence-based treatment is that you have to be able to generalize from a specific sample of people treated in a certain way to the situation that you've got right now. But those situations are often more complex than you can completely generalize from. So that's why it's important to kind of work this way. All right, I keep talking to you about this one way of thinking about different forms of healing. And I say we talk about an existential approach. That is, how does one human to another human as fellow passengers from birth to the grave help another person feel less alone and isolated? That's existential forms of healing. Existential forms of healing give psychological comfort, and they probably give out oxytocin. So there's probably a biological component as well as a fit or a meaning connection. Psychodynamic has to do with your developmental experiences with important people, your emotional connections to people who then become embedded out of your awareness and influence the way you perceive others every day in your life. That's the dynamic approach. The interpersonal is not one of us is the same with any other one of us. We warp each other. Our electron fields, a schizophrenic patient once came to me and said, stand back. You know, I want to talk to you, but your electron field is sweeping me in. That's a beautiful description. We warp each other's personalities by the forces that we create one-to-one and in groups. So no one person is ever the same in a different context. That's an important thing to know. You can work with those electron fields, and there's ways we can teach you about that. And then there's the thing that's more familiar to us, the biologic descriptive, the medical psychiatry, the disease states, the search for neurotransmitters and imbalances of norepinephrine and dopamine and too much glutamate and not enough GABA and all that. You know, that's the biologic descriptive approach. So we use all of those, and particularly we use the dynamic, the existential, and the interpersonal method to then create the right relationship and context with our co-investigator so that we can go to the evidence base of biologic descriptive psychiatry and apply the most appropriate approach. That's what we're trying to do. Okay, so that's that. We talk a lot about alliance formation and dealing with differences. We won't go through that now. I talk to you about this a lot. I say, look for the self. How do you find a patient? You look for the self on the shame-pride axis, okay? So the shame-pride axis, every one of us feels ashamed about certain things, that we feel incompetent, bad about ourselves. When you watch the limbic system speak, when the person feels shameful, they look down, they want to curl up and melt away. When they feel proud, they feel competent. Their shoulders go back, they stand up proud like that. When you're interviewing people, just watch the way their body moves, and as you see the beginning of the shame movement, you know where they're vulnerable, and you see where the pride movement is, you know where they feel good about themselves. You're finding them. And I always say, play that chord with your left hand. Once you find that chord, now you can explore dangerous places. Places where there's psychoses, fragmentation of psyche, despair, you know, suicidal urges. So I'm always asking you to find the self. I'm telling you a place you can find it in the limbic system and the cortex, and then move over and do your exploration that you must do as a doctor. All right. So you secure the self by validating the strengths that are really there, and you see where those strengths are, not just by the words they give you, but what their body does. That's what you're watching the face, the body, as well as taking cortical information. Okay. And you're trying to do this and get to these places so the patient's not so alone. This is the fundamentals of what you're doing all the time clinically. All right. Then I would say, what are the tools for finding the self and exploring the dark and dangerous places? So we go to Sylvan Tompkins, Nathanson, Bosch, the idea of empathy. So I'll just go over this really quickly, and then we're going to move to watch the residents who've been taught this way, how they work. And they talk about their work, and I'm just trying to show you this simple outline of this. So affect is preverbal, you know, and it's more powerful than words. And it's the same in toddlers, you know, young children, adults, and it even goes across mammals. But there's always an action tendency with an affect. I told you a core affect is shame. The action tendency is down, curl up. You know, pride is another affect. It's this way. You know, you have disgust, dismay, you've got an interest, excitement. They have core movements, core facial expressions across cultures and age. The affect is similar in everybody. When an affect occurs, then if you're conscious of it, you call it a feeling. So a feeling is I'm angry, or a feeling is I'm ashamed, or a feeling I'm interested. Okay, that's the feeling. Those things happen just like that. Emotion is a much more complex and personal thing. Emotion is the biographical processing quickly and unconsciously, sometimes consciously, but a lot unconsciously, of your personal history of anger. Who have you been angry with and about what stuff and what happened? That's emotion around that. The emotion of anger is this complex personal biography. It's different for everybody in this room. The affects are the same. The feelings, if you can recognize them, are the same. But the emotion is your personal history. It's a different story for each of us. Okay. So what we're trying to teach you is how to do that. If an affect gets triggered and you get into a circuit of emotional processing where you get stuck, you go into a mood that will last for hours, days, weeks, months, and many patients come to us for treatment for a mood. You'll find an affective moment that triggered an emotion, and then a circuit started reverberating and they're stuck in that. A depressed mood, an elated mood, an angry mood, something like that. Okay. So what we're doing, so then one of the psychoanalysts who was thinking about this kind of thing, Bosch, said that what we do during empathy is try out each other's affect display. Okay, the angry face, the prideful face, the interested face. You try out that because you all have the same stuff. And that triggers a weak experience of that really feeling inside you. And then we bring our own emotional experience to this and try to enter the world of the other person, realizing they've got a different biography of emotion around this. That's what empathy is. So when you know how to use these tools, now you can begin to find the person that you want to work with. And you have to have some kind of map of what you're going to work on, okay? So I'm going to just, I showed you a bunch of these maps, and we're not going to go into them today, but I'll just run them by you fast. These are maps that we work on when we explain things. I've translated the DSM-4 into this. So I use this particular map where I say the things we're really dealing with instead of depression, bipolar disorder, anxiety disorder, substance use, are really the HPA stress system, the dopamine reward system, the oxytocin, vasopressin attachment system, and then this true self, false self meaning making. So that's a broad map that I usually translate clinical information into to have a good conversation that makes sense to patients, much more sense than our psychiatric syndromes do, you know. But, you know, you see this map, this map, this map, where's the reward system attached? This shows what happens to your reward system when you overstimulate it. You know, the amygdala system's an important map. What does oxytocin do to it? You know, we use Fawcett's imminent risk map. We use Schneidman's cube, true self, false self, the PHQ-9. This is something that you should remember on the inpatient at the recent conference we went to. They said that the key actually warning signs that are robustly put in the literature, here are the two predictors of high risk for imminent suicide. One is within 30 days of discharge from a hospital after an overdose, and the second is non-compliance with treatment during those 30 days. And they said of all the risk factors, these are actually the most robust warning signs. So this was a suicidologist's recent recovery. That's a map. The anxiety scale is an important map. Suicidal tendency scales, a map that's important. So what I wanted to do today was just try to put into context what we've been trying to teach you in the interviewing seminar, in some of your didactic courses, in the multidisciplinary rounds. This is the framework on which we're trying to get you to be able to work clinically so that you can apply, use fit maps, and see what works for your patients or doesn't work, okay? So you sort of get, this is what we're trying to teach you. So now we're going to shift. So we gave you a bunch of maps. At the beginning of your residency program, we gave you this little blue notebook that has about 20 articles in it. So we want you to learn this stuff about forming relationships with patients, suicide risk assessment, managing your countertransference, applying the right evidence-based biologic treatments, and good luck, because it's scary and tough. And a lot of people are afraid of this, and a lot of people don't get taught this well. But that thing I just showed you is the framework we're working on, which this stuff about suicide and relational work with suicidal patients is one subset, okay? So what we did is we said, let's get a PGY1, a 2, a 3, a couple of 4s, and the first graduate of the program, Dr. Ayan Sol, and we'll ask him some questions about, is what we're trying to teach you about this stuff working? What have you learned? And then we'll see what they say, okay?
What I have observed in working with my patients who have been chronically suicidal or have attempted suicide but did not complete it, fortunately, that when they come back, when they came back to me in treatment, they were very scared about the relationship my patients and me had, and I think working with the patients in such a way that they do not feel that the relationship between them and their provider will be in jeopardy is, I think, it's a key part. And also I have observed that patients feel scared that if we talk about suicide, then we will be admitted to an inpatient facility. So they feel hesitant about talking about it openly. So I think working with them in a way that they feel so comfortable talking about that is can have like good outcomes. And again,
I'd like to follow up with you, Rizwan, so they become afraid about the relationship after a suicide attempt. And what are they afraid of, and what do you try to do to restore the relationship?
yeah, I have observed that they become afraid as if their providers will be mad at them, or they have failed their psychiatrist or psychotherapist by doing that. So they are very afraid of that, and they want to preserve that relationship. And when they come back, they are not sure that will they have that same relationship or not. So when they come back, like I've experienced in my patients who tried to attempt suicide and then came back, to make them feel that I am still there for their help, and trying to better understand their issues, as they have been thinking about suicide as a solution to a problem. So working around that, building some of the strengths around them, and creating such a holding place where they can openly talk about suicide without the fear that they would have to go to an inpatient unit every time they talk about it.
I was also thinking a number of the people I know of cases, a dramatic case we had was maybe about 10 or 12 days after a woman who had been worked with very, very carefully by members of our team decided to take her life, another woman came to the unit whose daughter had recently died either in front of her by suicide or perhaps an accidental overdose on her medications. And this woman, you know, in her late 50s was seriously contemplating killing herself in order to join her daughter who had recently died. And she had come to us after the chilling event of trying to carbon monoxide poison herself, but the dog of her daughter would cry when she was thinking of killing herself, so she actually had the dog put to sleep. And so we had the daughter dead, the daughter's dog euthanized by the woman, and she was just, you know, moments, hours, maybe days away from completing her own suicide. In the very same team that had treated the woman 2 weeks earlier who died now had to take on this challenge, and they did outstanding work. And I wonder if, you know, the people working on that case could talk about how they sort of managed their own feelings, how they moved forward, how they engaged this next most dangerous patient. It would be helpful to know. It was an act of great courage and skill and compassion.
I have to say that at the beginning of taking care of this woman, that I had the great support of my department, and knowing that that support was there personally for me was essential. It allowed me to move at a pace that was slow and thoughtful, and I purposefully took my time in how I attended to this woman, again looking for those blind spots, my own blind spots, struggling still with the sadness that I felt for the suicide that had happened just a couple weeks before. So the support of my team is essential. And what was interesting about that case, but is not untypical of suicidal patients that we work with, was that in the beginning, this woman wanted us to let her go. You know, she wanted to fight the admission and was adamant to be discharged. And there was that moment of that break in the alliance right at the beginning. I think Rosalind talked about it, where this patient was very angry with me, and I had to allow the disruption of the alliance to occur so that she would be safe, so that we were going to hold her in the hospital for treatment. And I had the great opportunity of working with a wonderful resident, Kranti, who did a lot of the repair work the next morning in creating that alliance, where she went to the patient sitting one-to-one and really started to build the alliance that would create the foundation for that treatment over the next week or so.
I wonder if Kranti, if you could speak about what you did, because when we interviewed the patient and she had made some kind of emotional transition, the patient said it was the compassion of Kranti and how Kranti worked with her that helped her move from an extremely dangerous place to a safer place.
So when I look back, what I understand what helped me build good alliance with the patient was just a good human-to-human connection, real genuine concern that I can feel her pain, what she's going through, and how painful was it for her to lose her daughter in front of her. And also understanding that how tunneling her thought process was at that time, and she did not see any other option besides dying and joining her daughter. And from when I understood what she is going through, she felt more hopeful, because I was hopeful that we can provide her more support. And she opened up and she disclosed her plan and what she was about to do if she was discharged the same day, and what plan she had to end her life. And like we talk in most of the cases, the family have a concern that they are worried about the safety of the patient, but that was not the case with this patient. When we had her brother come in, he was not worried about the safety, although we had a great concern. Me and Dr. Soul, we were worried about patient safety, and we did not let her go, although her brother was also insisting on discharging the patient.
I would ask you, Kranti, that so what happened was that you and Dr. Soul had to stand up to the woman and her brother who were saying, let her go, and she was very angry, but you two held firm on that. And the next day, you went in early to go and see her to see if you could repair that alliance when she was so angry. And when she told you what she was planning to do, if she had left that day, what was she thinking of doing when she explained that to you?
So just before she came to the hospital, she had tried carbon monoxide poisoning by turning on her car, laying in the trunk of her car, and she was planning to do and repeat the same. And she was planning to die that way. And she was also thinking that she is not going to inform her brother, who saved her during her previous 3 trials, and she gave a call to him, and who came and saved her. But this time she was planning that she is not going to take the phone with her, and she will complete the suicide.
When you were talking to her that next morning and trying to repair the alliance, knowing how angry she was at you and Dr. Ion Sol, did you notice in your discussion with her a moment when things seemed to shift? Was there anything that was happening between you and her that you noticed we're moving from one place to another?
So the conversation started with our introduction to each other. When I started talking to her, she had a lot of questions about me. So I had to do a little bit of self-disclosure, who I am, where I am from, and what sort of training I had in this profession, and a little bit about my family, from where I was able to pick up on how her relationship was with her daughter. Just she started comparing my relationship with the world and what relationship she had with her daughter. And she was able to share some of the burden, the guilt she had been carrying around since the moment of the death of her daughter, who she saw in front of her dying. And she had been a trained nurse who is able to perform CPR, but she did not perform CPR at that moment, and she was carrying a great deal of shame and guilt around that, and how difficult it had been for her to think about that, and thinking that she could have saved her daughter, but she did not try.
Where do people find the courage to do the work? And I've had the experience personally, and as a supervisor and as a program director, of having a suicide of a colleague or within the system, or of one of my own patients, and finding it for a while really hard to find the courage, and second guessing decisions, and I wonder if people have thoughts about how they have addressed that experience. I know Igor talked about humility and being humbled by it, which I think is certainly true, and kind of doubling back and being particularly thoughtful and careful. But I wonder what people have found useful, or could talk about what's useful in that setting.
Well, I've definitely experienced being terrified for a patient, and have been involved in the care of several that have died since I've been here by suicide, and take care of a couple that are pretty dangerous. And I think in terms of the courage, I think like Shadi was saying, that it's I guess I would call it compassion driven. It's feeling, really a deep feeling that people deserve to feel better than this, and with the inkling I have of the hopelessness, it's so lonely and painful feeling that I want somebody to be able to feel better than that. I don't want somebody to feel alone in that place. And I think that that drives me past my fear or my discomfort. But then when I'm by myself or walking down the hall or writing my note afterwards, I can experience quite a bit of fear. And again, one of the things that I'll do quickly, numerous times I've gone to supervision with Dr. Sabo or Dr. Donlin or one of my colleagues and said, oh my God, I'm terrified. I'm so uncomfortable, I'm crawling out of my own skin. And just being able to talk about that, because I don't think that there's a way to eliminate it. I think I'm hopeful and feel like it is happening in my process that I'll get better and better at managing my own feelings, but I think the feelings are just a true reaction to something that is really uncomfortable and painful and present. So.
And I'm sorry, I think it's so important at those moments to really take care of yourself too. And during those times, more than ever, you need to practice really, good, compassionate care for yourself. I had mentioned to Dr. Sabo that during my work with this very suicidal woman, the one that had euthanized her daughter's dog, that going into the weekend, I knew that I was going to be very kind to myself and taking care of myself, taking the time that I needed to walk in nature, to be with my children, to sleep well, eat well, so that I could be prepared for that Monday morning and the hard work that we had to do. So that's incredibly important as well.
I was impressed with that with Lara, that she recognized the emotional strain and the complexity of what she was dealing with. And she almost trained for it like a triathlete for a triathlon, or a warrior going into battle. And she did it through love, though, and self-care. I mean, she spent time with her children, walked in nature, meditated, and she knew that on Monday morning, when she left her family, she was going to have to go into a life and death struggle and deal with a tremendous amount of aggression and perhaps misinformation. And she knew she was in for a battle. And I was just really struck at the way she approached it, as she just described.
I think that insanity and mental illness is something very scary for anyone, layman or a professional psychiatrist. And suicidality is one of the scariest things we have to deal with. And unfortunately, I know that there is no vaccine against feeling that way, and no one is guaranteed not to be on the other side in this doctor-patient relationship. And just knowing and realizing that at the moment I'm more stable and I'm stronger and I can help somebody and possibly prevent death, this is something that keeps me moving. And remembering that, I just know that we can't stop, we cannot waste time. There are people in the darkest places in their life who are suffering and struggling, and they turn to us, and nobody wants to be an inpatient in mental institution talking to the psychiatrist. But these people, they have enough strength to be there for whatever reason. And we must continue to do what we are doing, because I know how many people we are saving every day. And this is just beautiful. This is just continuing life in a way. And remembering that keeps me moving, probably all of us.
When you're working in the inpatient setting and you're confronted with a suicidal patient, initially you click into that mode of assessing the situation, much in the same way you would if you came upon somebody, you know, in need of help. And you are assessing, and that is understanding the problem at hand, understanding the context of the problem, and gathering all of the information. And then almost unknowingly, you begin to use the tools that you learned during residency, the assessment tools, and you are, you know, going down and doing your checklists of what is happening, what's happening within the patient. You know, is there sleeplessness? Are there panic attacks? Is there agitation? And doing that initial assessment, understanding the safety issues. What is the lethality of it? Assessing if there are guns in the home. What kind of tools have been used recently for a suicide attempts or in the past. And so doing that general assessment. And that seems to click in. And then once that is done, there's almost this moment where you shift and start being with the patient in their despair and hopelessness. And as I've grown through my training, I've recognized the need to sit with and be with a patient during those really difficult times. And it's probably the scariest moment to go into that place of darkness and hopelessness. And initially it's about really just being with and understanding. And I've grown more patient and peaceful about that process.
I don't know what other programs do. I don't know how they train their residents, but I always feel like we have a really good balance between having more specific frameworks, you know, lists of suicide risk models, things that we can kind of, that are a little bit more tangible, that we can really hold on to, especially when we're starting to build skills, but also in addition to have a richer and more complex approach to patients as well, and not just be, you know, trying to fit them into a worksheet. And we're able, and I feel like we emphasize blending that together in a really nice way. And I don't think, you know, I'm assuming and I would hope that the education regarding that, you know, is a lifelong journey. It never really ends.
I think the attention to alliance, because I do think it's one of the most powerful tools we have for suicidal patients. And you guys are very attentive to making sure that we really work on how are we developing alliances. And I think it's remarkably potent. I also like the Schneidman's cube and the ability to like pick apart. So if some person is at this point where they're actually considering suicide, and how do we pick apart the elements that we could actually help them look at, help broaden their view. So there have been a couple tools like that. The true self and false self were also helpful for me in terms of having something to be able to hand a patient that feels that desperate or that, you know, kind of tunnel visioned.
As a future psychiatrist, any comments would you like to make that about the material about learning suicide prevention during residency training and its importance as you grow up becoming a psychiatrist? Any comments on that would you like to make?
I think it's a solemn duty of a residency program, you know, to take care of the residents that are coming into this field. I think it's a danger and something we'll be exposed to, and it's I'm delighted that it's so well attended to here.
Some of those material that Dr. Say will give us, like that huge manual in the beginning with all the information about suicide, and we keep reading over it over and over and over. Read the same article, Fawcett's article, over and over and over. And when we forget one of the eminent risk factors of suicide, I said, oh, it was panic attack, or was it alcohol abuse, or what was it? It's very important. Actually, I teach some of my clients now these studies. I teach them and go over them and let them learn how to monitor their risk, and how to, when someone kills themselves, usually there is a high adrenaline state. Usually it's associated with a lot of other biological symptoms, and it's all in the Fawcett study that's in the manual. So it's very important also to go with the patient over some of these very important studies. Make them simple, make them in their language, and make them able to understand it. And it helps, actually. It helps the patient and also will help the residents as well.
First, I am nothing extraordinary. A humble psychiatrist that has been well trained, and I feel that the program has provided me with the skills that I need, and I work with a faculty that continues to provide support and ongoing learning. And as many of my junior colleagues have mentioned already, that it is difficult work but good work, and we cannot know how many lives we save, and we are reminded of the severity of the work we do when a suicide does happen. But again, we can't know how many lives we save, and it keeps us doing the good work that we do.
Discussion or thoughts that you have about this. We started by talking about the process of a relational clinical therapeutics. How do you find a person and enter the work, and how do you then engage people with sort of the best evidence that we have in medicine and psychiatry to help people? And we just gave you an illustration of a group of people, residents in training and the first graduate of the program, who said, all right, here's how we applied this approach toward the problem of suicide and working with suicidal patients. And that's sort of the frame of what we're talking about today. So any reactions as you kind of either watch yourselves or your colleagues and think about this work that you're doing?
I was just struck again by the feeling that the Alliance is so important, like slowing down and going to where patients are feeling that desperate and that alone, that, any kind of connection that allows for an opening is just invaluable.
Just keep focusing on that.
Yeah, I think it's really important.
I think, Anthony, anything you think of as you kind of watch this?
I think the patient that they talked about in the beginning of that video, I think a lot of us felt better when she left because so many people did make that connection with her, and she felt, I think we felt she was comfortable coming back if she needed to before anything happened. So just on that last day specifically, different people had just a couple moments with her on that day that made them feel better, and that, I think made us all kind of feel better, knowing that she had that bridge back here and come back.
So a number of different people wanted to try to connect with. If you think about the imagery of a woman who, as Don taught us a couple of years ago, Thomas Joiner's model, successive experiments with suicide toward death. And this woman was putting herself in the trunk of her car. She'd take her cell phone, one last call to her brother, and now she was ready to go into the car. Her daughter was dead, the dog had been put to sleep, and she wasn't going to take the cell phone. And the kind of isolation of that moment against this team effort to try to help her find some way to connect with not just one person, but a group of people working together. That's really powerful, man. Other thoughts or feelings as you kind of watch this and think about the work we do? Are you thinking of something? I was just wondering if you had any thoughts.
I just, I find the whole sort of human engagement piece just really, really positive, you know, and
Yeah.
the language that's being used is not about diagnosis as much, or personality disorders, or
Right.
substance abuse. It's about something else, something that transcends all those things,
Right.
you know, because those things may be there, but they're of secondary importance to
Right.
making a connection and showing a degree of availability
Right.
to the patient. And that came across really strongly.
I thought Kranti really expressed it, you know, one human to another. And she actually really, when I've looked at this a few times, she described, I mean, psychoanalysts and other therapists have written paper after paper about what's the role of self-disclosure and the right boundaries on it. And she expressed in that little vignette, what is existential psychiatry? And what's the proper use of self-disclosure? Enough information to let the patient feel safe enough with you, and then move into her own material that needs to be processed. It's not about talking about yourself because you want to, you know, be the narcissistic center of the treatment. It's allow enough so that that woman felt safe and had a tremendous burden to kind of try to share, and then Kranti moved right over into the therapeutic work. That's as good as the best psychoanalyst who's been trained for 10 years could do, you know. And she hit existential psychiatry and that very important skill. She understood it as well as anybody and articulated it. It was beautiful. What do you think of that?
I really appreciate the way you and others have put together this map, these maps, because as I teach around in other areas, I don't see many people having that resource, and they're especially torn or caught up in their manualized treatments that are evidence-based, but they're not really making the grade with helping people connect with a human being in there, and so they see their patients kind of as separate, and they don't get the existential piece, which is so important. And when I teach people that, it's like I have people often in tears that are so relieved that they're actually on the right track with caring about their patients as people, and not being scolded if this is a bad thing or something like that. So.
Yeah, building on that, Lydia's comment about the fear that she feels, but compassion drives her past it to the isolation the person's feeling, and I've got to go there because the person deserves better. When I can do it, and then I'm shaking with fear, and I've got to process it with somebody else. I mean, that is courage. That's what courage is, not the absence of fear. I mean, fear is real, as you say, and she's not being uninformed or naive, but she's driven beyond fear to take a certain action and then process it with other people. I mean, the articulateness of these people describing their work is really as good as it gets. Very, very impressive.
Also coming out of an addiction world where patients are often rejected and blamed for their maladies and their horrible struggles and thrown out of treatment, which is a model that's still practiced, which is insane. But so this is so validating of that, you know, the addiction, as Newell was saying, is transcended by the existential connection.
Sean, anything you think of as you see this, and you're trying to improve, you know, sort of the patient's experiences when they're in the hospital, anything like that?
I think, you know, Newell and Mary have been talking a lot in MDPIs and medicine about that concept of self-care. While I was talking about how I'm going to take care of myself this weekend. In medicine, it's you know, we talk a lot about caring for ourselves and want to care for the patient, but I don't see that patients, the staff are doing it enough, or that we're caring enough, I think, for the staff. They're not dealing with the depth of darkness, which I think in watching this was just, you know, wow, you know, it's not like that. There's a demand on the providers that's different, but no less stressful and no less easy to deal with right now. As we start to put more and more pressure on people to follow these maps that are not based in human connection so much as protocols and clicks. And I think that's why I feel like I need to spend more time around you and the attendings and the residents. It's like I need to be reinvigorated, and I think the hospital, the health system can learn a lot about what you guys are doing right now. It's not going to be the same exact way, but to be able to figure out how we're going to meet those pressures by caring for ourselves and each other more.
I think we as a department need to accept that task, because we have all kinds of talented people who can make that engagement. You see a bunch of them right there. We're all capable of assisting in the thing that you're talking about. Mary, what do you think? As you work at the interface of medicine and surgery and psychiatry, and you know this stuff deeply in your soul that people are talking about here.
Well, number one, I'm just proud to be part of this department. I mean, I just am so amazed at the richness and the self-discovery and the synthesis of all the knowledge that you and Liza have put together.
It's everybody.
But I meant, I see the
depth.
depth of the program emanating from all the people that are in the video, and I just see their amazing skill. I'm just proud of being part of this department. I'm just amazed, and the central message that everyone's talking about is so evident. It's just, I love the words that people are. Lydia was so eloquent. Igor, like everyone, all of them just are really getting to that core of being present and not being afraid, and articulating a way to not be afraid to sit in that place with someone is really a special gift. I think it's a really important process that you're beginning to language so that other people can understand. And I agree with Sean that there are some other areas of the hospital where the time pressures that seem to be driving the forces kind of keep people maybe from feeling they can step into that for themselves, with themselves, as well as with their patients. But I think it's more than time. I think it's skill. I think some of it has to do with the courage, and also just the framework of understanding how you can be present. So a lot of that is there, and it's coming out in nonverbal as well as verbal ways. I love it. This is great.
It did make me feel really proud, and I'll just tell you that in an international conference, they treated us like rock stars when we just showed you and what you know and are doing. Like, how did they learn this stuff? Is what Terry Maltzberger wrote that famous hate-me countertransfer, came up and shook my hand and said, they're doing this. And Conrad Michel, a Swiss suicidologist, came up and said, I thought the Swiss were better than the Americans, but you guys are better than we are. So he felt competitive. He said, how did these people learn this? But it was this thing. It was competence. It's competence at compassion, connection, building alliances, understanding this. So keep up the good work. We'll keep trying. Thank you.